Okay, I got it now. I got it. Okay, let me try again. So first of all, thank you so much for inviting me to this prestigious meeting. It's definitely an honor to be here. So I'm actually going to talk about intracranial stent placement. So I want to talk about some of the clinical presentations of intracranial atherosclerosis, which obviously is the substrate for intracranial stent placement. So intracranial atherosclerosis usually can manifest in three different or can be detected under three different manifestations. The first one, obviously, that we are most aware of is ischemic symptoms. So a minor ischemic stroke, major ischemic stroke, or a transient ischemic attack, ipsilateral to the distribution of the stenotic artery. But actually, more and more recognition is coming on cognitive deficits, so that intracranial atherosclerosis actually leads to progressively worsening cognitive deficits. And the third thing is patients who have atherosclerosis in the intracranial circulation also appear to have atherosclerosis in other vascular beds. So sometimes the manifestation be other cardiovascular events, including coronary events. So essentially, when we talk about the ischemic manifestations, you can actually have a single ischemic lesion, which could be a cortical lesion, it could be a subcortical lesion, it could be a lacunar infarction. Sometimes you have multiple ischemic lesions in the same distribution. And sometimes it's a combination. So you have multiple ischemic lesions superimposed on diffuse white matter disease. So obviously, when some patient presents with intracranial atherosclerosis and ischemic symptoms, the purpose of intracranial stent is to actually prevent another ischemic event. So we have to understand when do the new ischemic events or the recurrent ischemic attacks actually occur in relationship to the first event. So here is actually a graph that shows you the proportion of patients who develop a new ischemic stroke or a recurrent ischemic stroke after the first ischemic stroke. And as you can see from this graph, that most of the patient would have a second ischemic event in the first 7 days, and most of them in the first 1 to 3 months. So almost 14% would have another event in the first 24 to 48 hours, another 14% in the first 7 days. And in high-risk patients, 52% may actually have another ischemic event in the first month or so. So really what it tells you is the risk of having a second stroke is high, and it's really highest very close to the first ischemic stroke. So there is almost like a time window. So if you want to do intracranial angioplasty and stent placement to prevent another ischemic stroke from occurring, you actually have to intervene very early. So essentially that time window may be as short as 1 month and maybe even 14 days. So we've always talked about time window for intravenous thrombolysis for acute ischemic stroke, but I think we have to recognize there may be a time window when we come up with intracranial atherosclerosis and an intervention to prevent a second ischemic event. And actually, if you look at just serial imaging, so serial MRI, so not clinical stroke, but subclinical strokes, essentially, you can actually see a large proportion of these patients would have subclinical ischemic events after the first ischemic event. So the burden of recurrent ischemic events is much higher. It's almost like 35% in the first week and another 8% in the next 1 to 3 months, if you're talking about subclinical ischemic strokes as well. So it does tell you that intracranial atherosclerosis, once an initial ischemic event has occurred, the patients are at high risk for developing both clinical and subclinical ischemic events. So does early treatment help? So this is actually a in-nested trial within the EXPRESS and SOS-TIS studies. And it actually looked at patients within 24 hours of transient ischemic attack on minor ischemic stroke. And it initiated antiplatelet medication, antihypertensive medication, and statin within first 24 hours after the first ischemic event. And if you look at the 1-year rate of recurrent transient ischemic attack and ischemic stroke or myocardial infarction, it was only 7% in patients, the 160 patients that had intracranial stenosis or occlusion. So yes, early treatment does help, and early treatment is effective in preventing a second ischemic event. So whenever we talk about intracranial atherosclerosis, and any therapeutic intervention, including intracranial stent placement, to prevent a second ischemic event, we have to think of doing this intervention as soon as reasonably possible. Now, intracranial angioplasty and stent placement has been evaluated over the last 25 years, and perhaps even longer, for patients with intracranial stenosis, for the same reason, because patients with intracranial stenosis have a high risk of having recurrent ischemic events despite medical treatment once they've had their first ischemic event. So there are two kinds of stents that have been evaluated. One is the self-expanding stent. The stent is delivered through a catheter, and it just expands by virtue of biomechanical property. And the second one is the balloon expandable stents, where the stent is actually mounted on the balloon, and the stent actually inflates, or it actually expands as the balloon inflates. And once the balloon stent is expanded past its elastic coefficient, once the balloon is deflated, the stent remains in its place, abutted to the surrounding vessel wall. So how does a stent work? So obviously we have to understand, how does a intracranial atherosclerosis cause ischemic events? So an atherosclerotic plaque obviously is more thrombogenic. So there's a higher chance of forming thrombosis that can lead to distal embolization, or even thrombosis at the site of the stenosis, leading to parent artery occlusion. And obviously there's narrowing of the blood vessel. And as a consequence of that narrowing, there's hypoperfusion of the distribution supplied by that blood vessel. So that also increases the risk of having ischemic events. So once you actually perform angioplasty and stent placement, you are restoring the vessel diameter to improve perfusion to that area of the brain. And secondly, you are actually causing arterial remodeling that reduces the chance of thrombogenicity. So there is changes in the angiostructure, or the microstructure of the arterial wall after angioplasty and stent placement, that actually prevents recurrent ischemic events. So this is actually an intracranial stent here. You can actually see a middle cerebral artery. This is actually after angioplasty and stent placement. And here you can actually see the stent within the arterial wall. 7 months later, the patient actually died because of a contralateral intracerebral hemorrhage. But it allowed us to look at the blood vessels under histomicrography. And you can actually see the cross section of the middle cerebral artery. You can appreciate the struts of the stent, and you can see the endothelium and the connective tissue actually grown over the struts of the stent. And this is what is the remodeling that reduces the thrombogenicity of the original plaque. And this is actually a lenticostrid artery. And I've always been concerned that if you're putting a stent across the origin of a small penetrating artery like the lenticostrid artery, you may actually occlude the blood flow to these small arteries. And here you can see that there's enough space between the struts of the stent that the origin of the lenticostrid artery is not affected, and the artery itself remains patent after stent placement. So obviously, in theory, intracranial angioplasty and stent placement can actually be beneficial. Obviously, you have to do a clinical trial to see whether it actually is beneficial. So there was a trial called the Stenting and Aggressive Medical Management for Preventing Recurrent Stroke in Intracranial Stenosis, or the SAMPRESS trial. This was a trial done in 2008. It actually completed in 2011, and it was actually a premature completion. So before the 764 patients that were supposed to be randomized were recruited, the Data Safety Monitoring Board recommending stopping the trial after only 451 patients, or 59% of the intended patients, were recruited. The trial was actually looking at patients who had 70% to get a symptomatic stenosis. They had to have a transient ischemic attack or a non-severe stroke within 30 days of enrollment, which was actually related to the intracranial stenosis that was 70 to 99% in severity. So the trial was actually interesting in that sense. There was a lot of emphasis on best medical management. And best medical management was to be done in both groups. So the patients who were randomized to stent placement also had to get best medical management. A stent group that did not get the stent also was randomized to best medical management. So patients with aspirin and Plavix for 90 days, patient had to maintain their blood pressure less than 140 to 90 millimeter of mercury, and a very aggressive LDL cholesterol goal, less than 70 milligram per deciliter. And obviously the group that needed the stent could be placed within 1 to 3 days after enrollment. So 451 patients randomized, 225 to stent placement and best medical management, and 227 to best medical management alone. But if you look at the 1 month stroke and death rate, it was very high in the stent group, 14%, as compared to only 6% in the best medical treatment group. And this was the basis for the data safety monitoring board to stop the trial, because they realized the risk of peri-procedural adverse event is so high in the stent group, the long-term benefit may never be actualized. So if you follow these patients for over a year, and the primary endpoint is 1 month stroke or death or 2-year ipsilateral stroke, so stroke in the distribution of the stenosis. So in the angioplasty stent group, 20% of them actually had that primary event, while in the best medical treatment group, only 12% had it in the medical management arm. So there is a significantly higher risk of adverse event with stent placement as compared to medical management. And it is primarily driven by a much higher rate of adverse events in the first month in the stent group. So really, the stent group had to perform better than medical management group. Then the peri-procedure adverse event rate has to be low enough that at 1 year, you're actually doing better than best medical management. So based on that, the Food and Drug Administration modified their criteria. So the wing pen with the self-expanding pen that was used in this trial had an approval from the FDA, and it was patient with 50 to 99% stenosis can be treated. They had to have 1 stroke or another recurrent ischemic event, which could be a transient ischemic attack. There was no need for a medical failure, and the time interval between index event and stent was not specified. So FDA modified the criteria after the Sampras trial. So now they said that only 70 to 99% stenosis should be considered. 50 to 69% stenosis should not be considered. Patient had to have 2 or more ischemic strokes, so not just transient ischemic attack, but ischemic stroke. Patient had to fail medication, so patient already had used an antiplatelet agent and could not actually, or still had recurrent ischemic events or ischemic strokes. And the panel also felt that there should be some time interval between the stent placement and the initial ischemic event to make sure the stent is not being placed in a time interval where there may be superimposed thrombus on the atherosclerotic plaque, increasing the risk of complication. So said that you must at least wait more than 7 days after the first ischemic event before performing the stent placement. So now we actually reanalyze the data, the Sampras data, after applying the on-label criteria. So using the new FDA on-label criteria, what would the results of the Sampras trial look like? So again, these patients are patients who have 70 to 99% stenosis of the intracranial artery, but actually have medical treatment, and the most recent stroke occurred more than 7 days prior to the treatment. So if you look at the on-label patients in the Sampras trial, it's a small number, it's only 31 patients, and compared to the off-label patients. So in the off-label patients, clearly you can see medical treatment is better than stent placement. But actually look at the on-label patients, there seems to be a signal that the on-label patients may do better with stent placement as compared to medical treatment. So there is perhaps some sense of validity of the new on-label FDA criteria when it comes down to selecting patients for intracranial stenosis who can benefit from intracranial stent placement. So the new FDA on-label criteria may identify a subgroup of patients who may benefit from intracranial stent placement due to a higher risk of primary endpoints in those treated with best medical treatment. Now, there was another trial called the WEAVE trial, and it was a post-marketing surveillance study after the Sampras trial to test the new FDA on-label criteria, and it recruited 152 patients. But in addition to all the standard parameters that were specified in the new FDA on-label criteria, it also required testing for antiplatelet resistance. So you have these platelet aggregometers. So you test to make sure the clopidogrel that you have started is fully therapeutic before actually doing the procedure. And essentially, at least 7 days had elapsed between the initial ischemic event and the stent placement, and general anesthesia was used on all patients. So in the Sampras, you could use local or general anesthesia. This time, everybody needs general anesthesia. And the trial was a short-term trial, so it was just looking at 72 hours. So it was looking at any stroke evaluated by a stroke neurologist or death. So within 72 hours, the rate was very low. It was 2 non-fatal strokes and 2 fatal strokes. So really less than 4% event rate, much lower than the rate that was seen in the Sampras trial, which may be because of the on-label criteria being used, or maybe certain things like antiplatelet resistance being tested before the procedure. So nonetheless, in this WEAVE trial, for the wingspan trial, a low peri-procedure complication rate was observed, and excellent safety profile was noticed. But there has been a lot of interest in balloon expandable stents. And I think the current thought among interventionists is that self-expanding stent is not the most effective way to treat intracranial stenosis. And perhaps a balloon expandable stent is the answer to treating intracranial atherosclerosis. So this is actually a trial that actually compared bare drug-eluting stent with bare metal stents, again, both of being balloon expandable stents, in patients with symptomatic high-grade intracranial stenosis. So 263 patients were randomized in 16 centers in China. And the patient obviously had to have a synonymous picture like what the new on-label FDA criteria is. They had to have a transient ischemic attack or a non-disturbing stroke within 30 days before trial enrollment. They needed to have at least one antiplatelet agent used and treated, and the qualifying event occurring despite the use of that antiplatelet agent, and needed to have 70 to 99% stenosis as compared by digital subtraction angiography. So the only difference from the US FDA criteria is that a transient ischemic attack could be a qualifying event, which is a little different because the US FDA criteria requires a ischemic stroke. So balloon expandable stents, so basically patients were randomized to either drug-eluting stent, 120 patients, or bare metal stents, 131 patients. If you look at the 1 month stroke and death rate, is 7.3% in the drug-eluting stent and 5.6% in the bare metal stent. Obviously much better than the rate that was observed in the Sampras trial with wingspan or the self-expanding stent. So clearly the 1 month stroke and death rate has improved either with the use of new FDA on-label criteria or with the use of bare metal stents. If you look at a 1 year follow-up, so you're looking at patients between 31 days to 361 days, and ischemic stroke in the target vessel territory or the ipsilateral distribution, 0.8% had ipsilateral stroke in the drug-eluting stent group, 6.9% in the bare metal stent group. So the rate is overall much better than the seen in the Sampras trial, but clearly a superiority of drug-eluting stent over bare metal stent when it comes down to ipsilateral stroke rate over the next year. And the explanation may be in instant restenosis. So obviously restenosis can occur. And the purpose of drug-eluting stent is to actually elute, which is to release the drug over a period of a month into the arterial wall. And these drugs are anti-proliferative agent. So meaning that the anti-proliferative agent that diffuses into the arterial wall prevents proliferation, which is the basis of restenosis. So you can see, if you look at the rate of restenosis after stent placement, 9.6% with the drug-eluting stent, 30.2% with the bare metal stent. So significantly better rate when it comes down to preventing restenosis with drug-eluting stent as compared to bare metal stent. So I think this trial highlights what most interventionists have already started to believe, that balloon expandable stents, particularly drug-eluting stent, may be the future of intracranial stent placement. So if you look at where we have started and where we've gone with intracranial stent placement, in the 90s, we started with balloon expandable stents. Then we actually switched to self-expanding stents. And then the Sampras trial was performed using self-expanding stents. And after the Sampras trial, now there is actually re-emphasis on self-expanding stents. So we're moving back to the next generation of self-expanding stents that are more trackable, more easier to deploy, but they may also have drug-eluting properties. In addition, there has been a modification of the eligibility criteria. So the new criteria may perhaps identify the patients who are most likely to benefit from stent placement, and perhaps some increased emphasis on monitoring the activity of antiplatelet agents prior to doing a procedure. And I think that most interventionists believe that we're heading for a new randomized clinical trial where we'll be comparing balloon expandable stents with best medical treatment given the new modifications. But I think we also have to be aware that while stent placement has been a very dynamic field, medical treatment is not static. Medical treatment after Sampras has also evolved. So there has been a new generation of antiplatelet medication and anticoagulants that are being evaluated. So perhaps the medical treatment is going to be more effective now than it was in Sampras. There has been increasing emphasis on not just treating the LDL cholesterol, but also treating serum triglycerides and maintaining them to a value of less than 135 milligram per deciliter. So that will also make medical treatment more effective. So I think as we plan for the next randomized trial, we have to be cognizant that both stent placement and medical treatment have been dynamic and have been evolving since the original Sampras trial. So the American Academy of Neurology Guidelines Subcommittee in 2022 came up with the following guidelines for stroke prevention in symptomatic large artery intracranial atherosclerosis. So they are actually recommending aspirin, 325 milligram per day, and clopidogrel, 75 milligram per day, in addition to aspirin, for 90 days to reduce the risk of or reduce stroke risk in patients who have severe intracranial stenosis, and severity defined by 70 to 99% intracranial stenosis, and who have a low risk of hemorrhagic transformation. They are also recommending high intensity statin therapy, and the goal is really to maintain LDL cholesterol less than 70 milligram per deciliter, not the standard less than 100 milligram per deciliter that we've been used to, but actually less than 70 milligram per deciliter. They're also recommending blood pressure treatment, maintaining the blood pressure to a value of less than 140 by 90 millimeter of mercury, and also recommending other cardiovascular activities or preventive cardiovascular strategies such as moderate physical activity. They are not recommending intracranial angioplasty and stent placement for stroke prevention in patients with moderate stenosis, so moderate defined by 50 to 69% severity, or as the initial treatment for stroke prevention in patients with severe stenosis. So again, emphasizing the value of medical treatment failure before deciding stent placement. So I'm actually going to conclude here with the following statement. I think intracranial atherosclerosis is no longer an untreatable cause of stroke. Aggressive management can reduce recurrent ischemic events and perhaps even cognitive deficits in patients with intracranial atherosclerosis. And we as medical professionals must support future clinical trials to ensure that the treatment of intracranial atherosclerosis is evidence-based and impacts favorably upon patient care. Thank you.
Thank you.